Thanks so much. We now have about 25 minutes for questions of this clinician panel from the audience. Step up to the microphones, and may I ask you to make the questions concise and to not involve too many questions about personal health.
Hi, my name is Margaret Jankalo. I am a pediatrician from Chicago, and this question is for Dr. Montoya. In deciding on antivirals that you use, can you let us know what criteria you use for them, as valacyclovir versus Valcyte, and also what the role of Immunovir is? Immunovir.
Thank you for the question. So I think there is a role to profile the patient's herpes infections, to attempt to obviously determine which ones they have, and a simple IgG should suffice. And then there are a few patients, or a percentage of patients that have the chromosomally integrated herpes 6. So I always get routinely the PCR for, in addition to the serologies, for HSV6. Occasionally, there is the chronic active EBV infection patient, so I get the EBV PCR as well. And then the next step, once you have a good history suggesting that that could be the case, then go first, or I go first with the acyclovir-like drugs, acyclovir, famciclovir, valacyclovir. It appears that in vitro famciclovir has better activity, so I tend to favor famciclovir. And then either if CMV is positive or HSV6 PCR obviously is positive because of the chromosomal integration, then I have a very low threshold to go to ganciclovir, Valcyte. And in that situation, one has to be careful with the monitoring and all the side effects. And the other important thing that we didn't talk about is lung. So we have found that the subgroup of patients that dramatically improves, does so given the antiviral for a year at least, and some require 3 to 5 years. And the Immunovir, I apologize, haven't tried much, but I know that there are some good clinicians and there are some data, I think Tony has more on that it helps. So we try to use it as well in some cases.
Thank you.
Okay, thanks. Good morning. I'm a caregiver, and I wanted to thank the panel and all the researchers here. After studying this disease and trying to treat it for 10 years, I have a better understanding now than I ever have. And I appreciate all your compassion towards patients. My question is, I'm also a professor of management and I'm a team science scholar. What can we do in the short term to improve translational work and, maybe drawing on the knowledge base of management organizations, science of team science? Is there anything that we can do to help you, the researchers, besides going to the Hill and advocating, which we did the other day, and also to help in improving medical education, diffusion of information and knowledge, so that in the short term we can improve the experience of patients in the doctor's office?
Anyone want to take that?
I'm not sure there are any easy answers.
No, there aren't.
I think in terms of exposing physicians and other providers to this illness, it really just takes everyone making an effort. Talking to them, directing them to continuing medical education, constantly, giving them papers and just drawing them in. I know that I hate to open up the floodgates, but if a doctor calls me during the day to discuss about their patient, I'll always take the call, try to give them a little bit of advice or schedule a time to talk to them. There is really a lot out there now, and I think mostly it's just awareness, and I think I see a lot of the more negative attitudes improving and disappearing, at least in the area where I practice.
Jose?
So in addition to The funding is a big factor. This meeting led by the NIH, Cindy Bateman and others are involved in this fantastic initiative called the Clinician Summit, and is supported and led by Mary Dymock in Salt Lake City, where basically decades of clinical wisdom that each clinician who has seen hundreds, if not thousands of patients have accumulated and need to be decanted and need to be distilled and put in some form of a place. So that is being done there, where all the wisdom coming from Cynthia on OIs and Susan's mast cells and Peter's autonomic and all the syndromes that Peter has discovered and Dan and Charles' lab and those who have some experience with herpes. So that is put together and results in something that is greater than the individual pieces of understanding of each person. So efforts like that needs to be done before we retire or die, because that needs to be somewhere. Yeah.
Thank you.
Over here.
Thank you. So a lot of us patients are taking a lot of supplements, and though I've benefited from IVIG, from mast cell meds, from POTS meds, a lot of the work that I've done nutritionally has really helped my recovery, and I'm not hearing any of that from you guys. So I'm curious as to how you're including functional medicine or the metabolomics work, or whether you're including functional medicine and naturopathic doctors at your clinicians' summits who do this work.
Just a comment on what we find in the adolescents. We have been interested in, for a long time, in the fact that many of them have upper gastrointestinal discomfort, reflux, and early satiety. And we published a paper about 2 years ago showing that in our cohort of 55 adolescents, 31% turned out to have a non-IgE mediated intolerance of milk protein. And removing milk from the diet as the most common of the allergens was associated with a much a bigger improvement in overall quality of life than we might have expected. It was statistically significant after 6 months. And so these people who are sicker than their non-milk allergic cohort had caught up by 6 months. And removing the dietary factors that can aggravate symptoms helps clarify what's left and what else you need to address.
There was just a study that came out that from Brigham and Williams or Women's about food allergies and medications. Most of the drugs that are prescribed have lactose and corn in them, which affect a lot of us.
Yeah, I wanted to say something. I didn't have time in my presentation to talk about luteolin or Neuroprotect, which is a flavonoid that I think is quite helpful and should be done in a clinical trial.
I usually individualize that kind of advice with a patient because it's not one size fits all with diets, and so usually just have a dialogue and have people really empower people to pay attention and investigate things and give them some backup and advice.
Yeah, Dr. Schuster.
Thank you. This is sort of directed to Dan and as well as everyone else. On the Powassan case, how well was that studied? Was it just molecular or antibodies? And the reason I'm asking is, and this may be the wrong panel, but just because you all see a lot of patients, but the approach is see a lot of patients or see a few patients and study them very intensely to get at the cause. This is just focusing on cause. Sorry to give it to you, but...
No, I'll take that. I mean, I think the deep phenotyping, which includes extensive evaluation, is the most valuable thing for that individual patient. But whether it extrapolates to the group of patients at large is a completely different question, and we need much more data on that.
Yeah, and I agree with that. And the other thing is Powassan is known to be transmitted by a specific tick. So we know that it follows the tick, so the scapularis, the Ixodes scapularis in the East Coast. So I think if a patient is in the West Coast and where the tick is not present that carries Powassan, then Powassan probably will not be indicated. So, and Ian Lipkin's group has fascinating work on tracking the presence of the organisms with multiplex PCR assays of what is carrying the tick and where the ticks are distributed. So there is some grounds for not doing Powassan in everybody, but in those where the epidemiology indicates.
No, I just meant in that case, how deep did it go? Including geography, where was the patient from?
Yes, over here.
He was from Manhattan.
Lucky.
Hi, this question is for Dr. Bateman. I'm curious if during your treatment of orthostatic intolerance, if you've found any therapeutic benefit to IV saline being administered to the patients?
IV saline is usually very effective. The problem is that access is risky, right? And eventually there's going to be some problem with access. So each individual case needs to be weighed. I personally kind of reserve it for rescue and maybe periods of time for people because of people with PICC lines eventually get an infection or a clot, et cetera, right, when you have a long-standing chronic problem. But it definitely can be helpful to help kind of bring people back up, or for special events like graduation, walking at graduation.
Dr. Rowe?
Yeah, we had, when we were first doing the tilt tests in the 94, 95 period, we noticed that our patients would have the development of hypotension, and then they'd feel worse for about a week. We very quickly realized we were not going to recruit very many people with CFS to the studies unless we fixed that. And the way we would get them feeling better when they left the lab that morning after crashing was with a liter or two of normal saline. And we've continued to do that as rescue therapy. Some patients who don't respond to any of the orthostatic intolerance medications, we will offer them weekly IV saline, in part thinking that if they can at least get a day or two of decent function, that's improving their muscle strength and tone and their overall function and activity better than not treating them. But as Cindy mentioned, the usual comment that we have about indwelling lines is it's not a matter of if, but when they will develop an infection. So those lines have to be managed with utter fastidiousness.
Thank you.
Yes, over on the left.
Yeah, I have two short questions for Dr. Peterson. Thank you for introducing a very excited area. My question one is that, because the AI is a big word, right? So could you introduce us briefly what method you're using or you see is going to be using, like whether machine learning or deep learning or shallow learning or this kind of thing? The second short question is related technically. Do you have any like a commercial software you recommend?
I can answer both together because I've only been exploring this for a couple months, and I'm interviewing a number of vendors with respect to the management of the data as well as developing the models. So I'll keep you posted on those answers.
Yes, Professor Geyer?
My question is related to Dr. Levine's talk, and the question is for the audience. Please raise your hand if you know what alpha-gal allergy is. So a handful of people know about alpha-gal, which is the tick-induced adult-onset meat allergy. And it can be elicited, the allergic reactions can be elicited even by gelatin capsules in your meds. It doesn't have to be just the meat. And the symptoms come on within 3 to 6 hours after you eat the meat. And so most people don't even recognize that this allergy, eating the meat, was the cause of their hives that broke out 3 to 6 hours later. So I asked Dr. Levine to just comment on whether this is another test that we should be doing in all ME patients to see how many have IgE anti-alpha-gal.
No, I think that's a good point. I mean, but in terms of the other symptom, the clinical presentation of PEM and just generalized fatigue, that sounds more like an acute episode of, I mean, I think it's a good thing to include, but that I think would be a more isolated type of episode if that person comes in with just that allergy. I'm not sure that alpha-gal allergy is associated with the ME phenotype.
Yeah, I'd actually turn it around. So this is about my wife, who was bitten by a tick in 2014. Before that, she was a mountain hiker. She gradually went downhill over the last 4 or 5 years. Every possible test, including next-gen sequencing, was negative. And the only thing that came up positive was this past November, I came home and she was having a near-fatal anaphylactic reaction. And so then we learned about alpha. I taught hypersensitivity to medical students for 30 years. I had never heard of alpha-gal allergy until it happened to my wife.
Yes.
Given that a lot of these individuals have recurrent herpes virus infections that are neurotropic, and the recent evidence linking that to the development of Alzheimer's disease, Parkinson's disease, have you guys seen in your clinical practice any of these individuals transitioning into mild cognitive impairment and then on to either a movement disorder and or Alzheimer's disease?
I have not seen the Alzheimer part, no. The CFS patients, there is a subgroup that have ill-defined neurological symptoms that are hard to box in one area of known neurological disorders or other, but clearly they have neurological flavor. And in that subgroup, when they respond to the anti-herpes therapy, they seem to gradually get out of that neurological complaint. So, but not bona fide Parkinson's, Alzheimer, I have not.
I think also when we develop biobanks in the future, and we stain the brain tissue, we'll know then for sure, I guess, if there's a greater prevalence of that among the ME patients. But I don't think any of us really can tell at this point.
Yes, over here, Sadie.
Tony, you alluded to this at the start of the presentation, and I know, Cindy, you do a lot of work in this area, but what approaches can we take as a community to bring more clinicians into this field?
I think more material online and more material on in those online sources that are most heavily used, like the up-to-date online textbook of medicine, is definitely needed. The information that has been out there until the last year or two is, in my judgment, inaccurate and really not very helpful at all to the practicing physician. So most patients with this illness are probably being seen by generalists, general internists, general pediatricians, and very few of them, I think, are likely to focus their practices largely or exclusively on this illness. But all of them need a lot more help in managing patients because ignorance on their part is doing damage, I think, to the care of a lot of patients. So, and the Clinician Summit that Jose Montoya mentioned a minute ago that Dr. Bateman has been organizing will hopefully generate a lot more helpful online information. And several of us are working on online sources like Up to Date to improve the quality of that information as well. But to be honest, there is a real financial problem for generalist physicians to take care of patients with this problem because the fee-for-service reimbursement system does not provide enough support for the time needed on the part of doctors. And so changing the reimbursement system, like working with capitated systems like the Kaiser Permanente system to improve what they do because the financial issues are reversed in the capitated system. There, it's really imperative for them to do as efficient a job as they can, and they don't have to worry about getting paid on the per minute or per hour basis. And there are initiatives, several people in this audience are working with organized capitated group practices to help them improve their care. So, but it's not an easy thing to do.
So this is a very challenging problem, and I have to say I've put many long hours in different settings into this question of how do we take this material to practicing physicians. And we had a subcommittee on CIFSAC to try to work on it. And at our nonprofit, the Bateman Horn Center, this is one of our major parts of our mission, is to try to create materials and opportunities for physicians to be trained. And really, there's no easy way to do that. So we're trying to do it on multiple fronts. So the clinicians who attended the summit, the Clinician Coalition, we're going to try to create, and we're working on it and have some of it done, but some consensus materials. We hope to set up a website where we can put some of those consensus materials so they're easy to access. Again, though, how do you let doctors know that it's there? We're working on materials that we can give people to distribute. And we also have a listserv that we've started among us that we hope to grow, and so that interested people who want to become more expert physicians in this area can join our listserv and contribute to what it is we're doing. But honestly, it's hard to do things without funding and infrastructure. So one of the reasons I changed my clinic to a nonprofit model was to open up the doors for other funding sources. But to really provide a product, you have to be able to support it financially. And that's the only thing I think that's slowing down our efforts.
Tony, one other comment would be that I think there are a lot of people who are thoughtful and creative in medicine, but they need to have the financial backing to put a career into a complex chronic illness. And I've advocated for something like a Ryan White initiative that was done for HIV for this illness. And I think if the money is there to support academic careers, we're going to have centers at every single university, which is what this population deserves.
There is one handwritten, I'll come to you in just a moment, but before you went to the microphone, one handwritten question was submitted by someone who can't go to the microphone. And it's directed, I think, Dr. Montoya, at you, but others free to answer. With a patient who developed ME/CFS after EBV mononucleosis at age 17, how do you determine if she is a candidate for herpes suppressant treatment?
Because of interest of time, careful history again, that's crucial. But a good candidate, for instance, will be one that persists with the viral-like symptoms. It will be one that perhaps will have very high levels of VCA, IgG, or it will be IgG, EBNA, or EA positive. If they have obvious positivity for PCR, then they will be falling probably in the group of chronic active EBV rather than chronic fatigue syndrome, but it will be the fatigue syndrome associated with the EBV being chronically active. So those patients probably would be good candidates for antiviral therapy.
I think we want to wrap up this session now. Thanks everyone on the panel for a very stimulating session. Thanks the audience for your questions.